Hello, and welcome back to yet another episode of the Core Consults RX podcast. Cole, how's it going, man?
It is going okay. How about you, Mike?
Can't complain. Just another Friday doing the podcast thing.
Yeah.
Did we ever think that we'd be spending our Friday nights doing podcasting?
No, but is there a better way to spend your Friday night than podcasting?
No, definitely not. We party hard, but we are going to be doing another accredited episode today, and this is not a. You said we haven't covered this for an accredited episode?
Not that I could see. Unless I missed it, not that I could see.
So we've done this topic before. It's probably been a while, but we're going to cover Parkinson's disease today. And so hopefully this will be a good review. And, if you are already a member of freece.com, have an unlimited membership, you already have access to, getting credit for all of the podcast episodes that we have available. I think there's over 60 now. And if you're not a member, check out their library of content. They have a lot of great stuff on their website. And appreciate them, as always, for continuing to work with us.
Absolutely.
But do you want to jump right into it? Anything you want to start with?
I mean, we'll talk a little bit about the Parkinson's disease pathophysiology. We've touched on it before. And as far as what it is, since we're going to be thorough, it's an adult onset progressive neurodegenerative disorder. It's been described originally hundreds of years ago as shaking palsy. James Parkinson was the first one to describe it a couple hundred years ago, which is why it's termed Parkinson's disease. It's traditionally considered a motor system disorder, but they've kind of realized that it's a little more complex than that, involving a wide range of non-motor manifestations that contribute to the disability of Parkinson's. And the incidence has risen, as you would anticipate, with the aging population increasing. Normally, it's going to be over the age of 50. About 25% of people with Parkinson's are diagnosed before the age of 65. The average age, or I guess the mean age of diagnosis, is 70 and a half. But there's definitely plenty of people who are diagnosed much younger than that.
70 and a half. You think people, I remember when you were a kid and you tell everybody you're like, I'm, 10 and a half, or because you're constantly trying to be, once you hit 70, there's no way you want the half year.
So you might want the half. So you're almost 71. No, I'm 70 and a half.
I'm 70 and a half.
You want the half.
Yeah. Don't you round up on me.
Don't round up. No.
Yeah.
70 and a half.
But from a population standpoint, its estimated prevalence is approximately 0.3% in the general population, 40 years of age and older. And like Cole said, as you get older, the risk of developing it does go up. And males do tend to have a higher risk of developing Parkinson's disease compared to females by a ratio approximately of 1.4 to 1. So not a huge increase for males, but definitely a little bit higher risk. And a family history of Parkinson's disease in a first-degree relative is associated with a 2 to 3-fold increase in the risk of developing Parkinson's disease. So obviously when we're getting family histories, if there is any sort of concern about mild tremor-like symptoms or anything, take into account that, if they have any close family members that have a previous diagnosis, because there is a genetic component to it.
Has anyone in your family had it that you're aware of?
Not that I'm aware of. No, I don't think so.
Mine either. And but my wife's granddad did, and that's kind of what prompted her to go into medicine. I can't remember what episode she came on for. It was either migraine. It might have been migraine.
She did
our original ones.
Yeah, she came on. She came out for migraines, I believe.
It was migraine. Okay, yeah, and I'm sure I think she probably mentioned it because that's kind of what prompted her to do that. And then she went on to kind of manage patients with dementia, and well, as we'll see, Parkinson's can frequently lead to a type of dementia. So
yeah.
Yeah.
There's also some environmental exposures that we've sort of identified that are also potential risk factors for a patient developing Parkinson's. So things like exposure to pesticides, exposure to air pollution, high consumption of dairy products, farming or agricultural work, living in a rural area to begin with, is also a risk. The use of well water, which that one kind of surprised me a little bit. And then a high dietary intake of iron, especially if it's in combination with a high manganese intake, which, I don't know how many of us are watching our manganese intakes, but something to consider, I guess. And then also,
I don't even know what is high in manganese. If you ask me, I wouldn't know that off the top of my head.
Yeah, I couldn't tell you much. I would assume some fruits maybe, but I have no clue.
The dairy products are interesting. They're just always attacking dairy, and I'm like, I like my milk.
Well, one of the other risk factors is reduced levels of dietary or sunlight-derived vitamin D. So counterintuitive. So it's something else with the. So
you just need the perfect amount of dairy.
You need the perfect amount of dairy, or just sit in the sun more and get outside.
Yeah. There are a variety of other medical psychiatric illnesses in early or midlife that have been associated with increased risk for Parkinson's. It's not really like hard data, more observational studies, but there seems to be an association with obesity and other metabolic syndromes, diabetes, type 2 diabetes, history of a traumatic brain injury, history of melanoma or prostate cancer may increase risk as well.
Diabetes, man, puts you at risk for so many things. It's crazy.
I know.
But there are some protective things to consider, some protective factors, if you will. One of the protective factors that may surprise you is smoking. So there was a meta-analysis that looked at 26 observational studies and saw that the risk of Parkinson's disease was more than twofold lower for current smokers when compared with people who had never smoked before. So that's pretty interesting.
I have a theory.
Tell me.
They didn't make it to 70 and a half. They didn't make it.
That could be a theory.
I want to see what do they call it? The average lifespan was for the patients who smoked, and I bet it was significantly less than the other patients in the study, and that's why they didn't develop Parkinson's, because they didn't make it long enough to see the symptoms. Possibly.
There's also another theory, and I think this is mine that I'm kind of going with, because there has been some correlation between like patients who use like long-term amphetamines or like methylphenidate or something for ADHD, and then nicotine consumption, and apparently that can be protective of some of the over dopaminergic activity that you may get from the stimulants. Gotcha. So I'm wondering if that's probably the factor. So
as long as you don't die from a heart attack before you develop Parkinson's, then it'll protect you from Parkinson's.
Right. So smoke, but take a statin. Keep your blood pressure. There's a lot of variables you have to really watch.
Yeah, you use your amphetamines, but exercise and stay heart healthy. And you will be protected.
Yeah, that's obviously not true. So don't follow that advice. But it's weird to find when you see something like, smoking, because like ulcerative colitis we talked about a few weeks ago, it has some protective properties there too. It's kind of odd that, every so often nicotine comes through in the clutch, but just all those other noxious particles you're inhaling that also don't help.
I wonder if vaping will be included like years down the road in these studies where they're like, vaping nicotine was X or Y, increased or decreased risk of this or that,
Turns out vaping is just the best thing you could ever do. That would be funny. But
all those annoying people
probably not.
The smoke everywhere. Turns out they're the most healthy people out there.
Yeah, they just live forever. That's going to be such a slap in the face if that's the case. But some other things that have been shown to potentially lower risk, caffeine. So coffee as well as caffeine, overall caffeine intake have been loosely associated with lower risk of Parkinson's disease and a few meta-analyses. Exercise, which that makes sense. Obviously, exercise tends to help everything, but aerobic exercise in particular and increasing just physical activity may have some protective properties as well. And then there's actually some limited studies. It's not like it's great data or anything, but there's some data that shows that ibuprofen potentially could lower the risk. And then also the alpha-1 androgenic receptor antagonists, so the alpha blockers. So, for example, like doxazocin. So, and there is a whole mechanism. I can't remember what it is, but I saw it on Up to Date. They kind of explain the theory behind that. And then also like things that can inhibit the RAS system. And so the ARBs, I think, are what actually have some data to support that. And then our best friend ever, GLP-1s, actually have some very limited data. I think the study that I was looking at that showed that it may have some protective properties was actually with lixisenatide, Adlixin, which I don't even know if they have that in the market anymore. But there was like this very small study that showed some limited benefit, but I think they did another study with exenatide, the original Byetta Bydureon, and that one I don't believe had any benefit. So it may be a agent specific thing, but who knows? GLP-1 sure are helping quite a lot of things, it seems like.
Somehow I'm not surprised about the Byetta thing.
Yeah. Byetta, although it was first, we had to start somewhere. Seems to be not the best. They've gotten a lot better at making GLP-1s.
Yeah, first is sometimes worse.
Yeah.
Okay, so what really makes Parkinson's disease unique, and especially with the diagnosis, are the clinical features that you notice. And this is usually what you associate with Parkinson's disease in your mind, because that's what you visually see from people. But also they are very characteristic of individuals with Parkinson's. One is the tremor, specifically the resting tremor. The severity usually decreases when people make purposeful movements or actions, and it's more severe when they're resting. There's an upper extremity tremor that they might describe as pill rolling because of the way the thumb and forefingers, or I guess the thumb and fingers, appear to be rolling like a small object between them. The tremor can involve the legs, the lips, the jaw, the tongue. It usually does not involve the head. In the early stages of Parkinson's, the tremor is usually intermittent, happens occasionally, might not even be noticeable to others, but it will become more severe over time. It usually starts on one side. It's unilateral in the hand, and then can spread to other areas. Usually takes years and is progressive. Anxiety, emotional excitement, stressful situations, all these things can exacerbate tremor. I remember my first interaction with a patient who had Parkinson's, which it was long before I knew anything about anything medical. I think we were doing a visit to like a nursing home. You're young, you go and visit and like talk to people and stuff. And I remember talking to this guy who was in his bed, and his tremor was severe. And it made him kind of move around a lot. And I remember it being very anxiety provoking for me. And it took me, I don't think even at the time I knew he had Parkinson's, it took me a while to realize that he did. But it was very distressing, the amount of tremor that he had. I'd never seen anything like it before, but it definitely affects them significantly.
I can't remember, this was a while ago, but I mean, there was some, like, I want to say it was like an engineering student or something that came up with like that spoon that was like, it was a spoon or a bowl. I think it was a spoon. Yeah, it was on some kind of like a gyro, whatever you call that thing. It keeps the balance no matter which way you like almost like a gimbal for a camera. And like he was able to eat, patients were able to like eat cereal and stuff that had like severe tremor where they normally couldn't hold anything in their hand like that. I'm pretty sure that was a student that came up with that. It's pretty cool.
Oh, really? Shout out to the engineers. I bet that he was a biomedical engineering student.
Yeah. We should have been engineers. That would have been cool.
Yeah, my dad was one. My dad always said, "Don't become an engineer."
Right. That's just what everybody says about their own career.
I know. And then I'm like, well, don't go into medicine.
Yeah.
That's what everybody says.
People are like, "You can tell your kid to be a pharmacist?" I'm like, "No." Tell him to be a physician.
Everybody thinks they have it the worst.
Yeah.
Everybody does. So if you actually are sitting there thinking, "No, I don't. I have it the best," you must have it really good then, because everybody thinks that their job is the worst thing ever.
Or you're just not negative like we are.
I know. Hey, actually, I love my job.
No, that's good. No, I do like being a pharmacist, but there's always that thought. I'm like, probably should go into medical school. Things would have been a lot easier to be more entrepreneurial if I didn't have to, if I had provider, status and all that good stuff. But I digress. Another cardinal feature of Parkinson's disease is bradykinesia, which is just this generalized slowness of movement or decreased amplitude of movements. It's the most common feature and is an early symptom of Parkinson's disease. And although it's the most common, it's also the most difficult symptom for patients to sort of describe what they're feeling. So they may use terms like, weakness or incoordination, tiredness, and it's basically just that they're kind of describing this decreased ability to initiate voluntary movement in the early stages. In the arms, bradykinesia typically starts distally with decreased manual dexterity of the fingers. So patients may end up, as time goes on, having difficulty with things like buttoning their clothes, tying shoelaces, double clicking, a computer mouse, et cetera. Obviously, things that can, if you're not able to do suddenly, it can decrease your quality of life pretty drastically. And when it comes to like the legs, common complaints related to bradykinesia, typically when they're walking would include like dragging the legs, having like shuffling steps, et cetera. So bradykinesia is another very common thing that most patients, especially as time goes on, will develop some form of it.
You ever watch Modern Family?
No.
Hilarious show. You should. But there's a great episode about double clicking in an older individual in the show having difficulty understanding the concept of double clicking because he was double clicking and it just wasn't doing it. Just hilarious. Also, have you heard this term that kind of pops up in meetings when somebody says, like, let me double click on that for a second, and then they start, like, digging into whatever this topic was? It's like the new circle back. They're like, let me double click on that for a minute, and
I hate that already. I haven't heard anybody use that, but I hate it already. The first time I hear somebody use that, I'm going to lose it. Because I hate circle back too. I'm like, no, let's just talk about it now. Why are we circling back?
I know.
Let's get stuff done.
Let's do it now. And then, but I guess, that's what double clicking is. Double clicking is let's dig into that a little bit. We're going to double click on that and talk about it.
I love that they have to tell you what they're about to do. Why don't you just talk about it? Don't narrate what you're saying. Now I'm going to talk about this. It's like giving the objectives. Like, we know what you're going to talk about. Let's roll. Anyways, sorry. Man. What about rigidity?
Yes, rigidity. So another cardinal feature. Rigidity is an increased resistance to passive movement that is kind of around a joint. It can't affect any part of the body, might contribute to complaints of stiffness and pain. Symptoms that result from rigidity could be striatal hand, decreased arm swing with walking, typical stooped posture. All these would be classified under rigidity. Also, another feature of that is pretty distinct to Parkinson's is a cogwheel rigidity, kind of a ratchety pattern of resistance and relaxation. As if you were to move the limb, if somebody was to press down on the limb, they would see that it kind of has a cogwheel shaking. Oh, we're on camera. A cogwheel shaking. I can actually show you. Through like the full range of motion. Some patients will have a lead pipe rigidity, which is more of a tonic resistance that is smooth throughout the entire range of passive movement. So it can take different forms, but all of that is rigidity.
And also postural instability is also kind of usually lumped in with the cardinal features. So it's basically a decreased ability to prevent falling, and it's caused by impairment of centrally mediated postural reflexes. It is the least responsive to dopaminergic therapies, which are kind of our main go-to medication options and classes. It usually does not appear until later, in the course of Parkinson's disease. So someone's usually been diagnosed for a while before they start dealing with this. Not always, but it's kind of the usual schedule of things. And then initially a positive pull test on examination may be the only sign of balance impairment. And so it's tested with the pull test, and the examiner stands behind the patient and firmly pulls the patient backwards by the shoulders. Of note, the pull test is not valid unless the patient takes at least one step backwards. But obviously someone that has this postural instability will lose their balance and may take several steps backwards.
It's interesting.
Yeah.
Dyskinesias are also a characteristic of Parkinson's disease. This is different than bradykinesia. This is more of a, or rigidity, or tremor. It's more of an uncontrolled involuntary muscle movement that's irregular in motion, unlike the rhythmic, regular movements of a tremor. It can be standalone, but it's most often associated with long-term use of treatment medications like levodopa or other meds. Levodopa-induced dyskinesia can involve symptoms ranging from writhing or wriggling to dramatic rocking and head bobbing. And I mentioned that that kind of first patient that I ever experienced with Parkinson's had a tremor. It was actually more likely levodopa-induced dyskinesia with the amount of movement he was having. Mm. But yeah.
Well, I think that's something too, like that. It can get confusing because, like, and I've had several students ask me about that. Like, well, you're giving something for a tremor, but then dyskinesia at first glance kind of sounds like very similar to a tremor. So that's a side effect of the medication. They are two separate things, which is why they obviously have two separate names. But it's important to know that distinction because it can get confusing.
Right. And part of the management that we'll talk about is dealing with that side effect,
right?
Using this or that to mitigate it and that sort of thing.
So, there's three major clinical subtypes, if you will, of Parkinson's disease. So they've been described based on the predominant feature. So it may be tremor dominant, akinetic, rigid, or postural instability and gait difficulty. So the patients will oftentimes fall into one of those subcategories. Tremor dominant subtype is associated with slower progression and less neuropsychiatric impairment than the other two groups. And, not that any of them are pleasant to deal with by any stretch of the imagination, but when you start dealing with the neuropsychiatric impairment and psychosis and some of the hallucinations potentially and whatnot, that can obviously even worsen that already poor quality of life that the patient's experiencing.
Right. And like Mike mentioned, I'll highlight a few of those non-motor manifestations, which from the patients that I've talked to frequently are more impairing than even the motor symptoms, which sometimes, since we have medications that can help control those, the psychiatric symptoms can many times be more difficult to control. And a lot of the medications we have to use are not great in elderly individuals. So, but the examples would be cognitive dysfunction and dementia, psychotic symptoms like Mike mentioned, hallucinations, delusions, mood disorders, depression, anxiety, apathy, sleep issues, chronic fatigue, autonomic dysfunction, olfactory dysfunction, GI dysfunction. All these can come along with Parkinson's and the motor symptoms.
Yeah. And I agree. I feel like not that I've had a ton of experience with Parkinson's patients, but the few that I have dealt with, in fact, a couple of them in particular that I'm kind of come to mind have had the psychotic symptoms, the hallucinations and all that. And then they, from their point of view, those are significantly worse to have to deal with than, some of the motor functions that they've kind of learned to deal with or learned to manage with medications, and then all of a sudden they start having some of these psychotic type psychosis symptoms, and it's a whole nother ball game to deal with. It's got to be.
There's a big caregiver burden, especially if there's a spouse involved, and they can help with the motor symptoms and make adjustments and work around it, but it's very challenging to deal with the psychosis and the psychiatric symptoms.
Yeah, like you said, not a lot of great options out there for treatment.
Yeah.
But I'm going to go too far into the pathophysiology, but and mostly just so I don't have to pronounce any of these neural terms. But the brains of patients with Parkinson's disease typically show depigmentation, neuronal loss, gliosis, and particularly in the substantia nigra pars compacta and in the pontine locus coeruleus. Sounds like a Roman emperor. And the ventrolateral portion of the substantia nigra that projects to the dorsal putamen is preferentially affected early in the course of Parkinson's disease, which is resulting in that gradual loss of dopaminergic neurons and nearly complete depletion of dopamine. Particularly in the putamen, which the dopamine is, as we see when we get into the medications, is kind of like the main target of a lot of these medications.
Right. As far as diagnosis goes, this is primarily a clinical diagnosis based on the many features that we just talked about, it's important to kind of distinguish between it and other things that could cause Parkinson's or like symptoms, like medications and other things like that. So they have some detailed diagnostic criteria. Primarily, it needs to be there needs to be at least 2 supportive criteria without exclusion criteria or some other reason why it wouldn't be actual Parkinson's disease. One supportive criteria is distinct benefit in response to dopaminergic therapy. So they might have marked improvement across various ways that they use to kind of monitor that. There's a UPDRS-3 kind of score, and if you saw a greater than 30% improvement in that, then that would be an example of that. A presence of levodopa-induced dyskinesia would also be a supportive criteria. A resting tremor of a limb documented on clinical exam would be a supportive criteria. And also the presence of either olfactory loss or cardiac sympathetic denervation would be another example of a supportive diagnostic criteria.
And then some absolute, exclusion criteria, like Cole said. And so part of you have to have 2 supportive, but also making sure that there are not any of these absolute exclusions. So just to name a few, I won't read through all these, but things like diagnosis of probable behavioral variant, frontotemporal dementia, or primary progressive aphasia, things like treatment with a dopamine receptor blocker or a dopamine depleting agent in a dose and time course consistent with drug-induced Parkinsonism, kind of like Cole mentioned earlier. Absence of observable response to high-dose levodopa despite at least moderate severity of disease. Normal functioning neuroimaging of the presynaptic dopaminergic system. And documentation of an alternative condition known to produce Parkinsonism and plausibly connected with the patient's symptoms. And, there's a few others, but making sure that, you've kind of checked those boxes to make sure that, you're not diagnosing the patient with Parkinson's disease when it's in fact not. And there's also they're not exclusions, but there are things that they refer to as red flags, that may kind of, push you in another direction besides Parkinson's. So things like rapid progression of gait impairment that requiring regular use of a wheelchair within 5 years of onset, a complete absence of progression of motor symptoms or signs over 5 or more years unless stability is related to treatment. Another would be like severe autonomic failure in the first 5 years of disease. So they can include like orthostatic hypotension, orthostatic decrease of blood pressure within 3 minutes of standing by at least 30 millimeters of mercury, systolic or 15 millimeters of mercury diastolic in the absence of like dehydration or medication-induced orthostasis or something, or severe urinary retention or urinary incontinence in the first 5 years of disease, excluding long-standing issues with stress incontinence in females or something like that. And again, there's a few others. We won't name all of these, but the red flags are not complete exclusions, but they are things that you should basically take into consideration. And one of the sort of the criteria application, if you will, when you kind of get to the end of this checklist is, you're adding up how many, supportive criteria, like Cole said, are there at least 2, supportive criteria? And then the question is like, is there no red flags? And if the answer is no, then, you have to look at how many, is there 2 or more red flags? And is the number of red flags equal to or less than the number of supportive criteria? If the answer is yes to that, if the supportive criteria do outnumber the red flags and there's no exclusion criteria present, then, the patient probably meets the criteria for Parkinson's disease, or at least it's probable that they would meet that. And again, there's obviously more that goes into the diagnosis of it, imaging and those other things that can be done, but this is sort of a checklist that clinicians can follow to kind of, go through their differential while they're working up a patient.
Right. As far as the differential goes, some things that you would want to rule out, or that might look like Parkinson's when it's not, could be a prominent tremor or an essential tremor. Some clues to it not being related to Parkinson's could be that it's more bilateral, whereas Parkinson's usually starts unilateral. If it involves the head or the voice, If it's not present at rest, unless it's severe, if there's no involvement of the face or legs, if there's a family history, or if it's relieved by alcohol, could be clues that it's not a Parkinson's related tremor. There's also secondary Parkinsonism, which is something that is something's happening or something has happened that is causing there to be symptoms of Parkinsonism, but isn't necessarily related to the exact patho of Parkinsonism. Drug-induced, we've talked about this with other medications in the past, but certain antipsychotic agents, metoclopramide, prochlorperazine, valproic acid, they can all cause drug-induced Parkinsonism. Vascular, so there can be vascular Parkinsonism or vascular dementia. Toxic substances like carbon monoxide or organic sulfates. Certain metabolic syndromes can cause some symptoms of Parkinsonism, like hypoparathyroidism, chronic liver failure, end-stage kidney disease, infectious causes like encephalitis or HIV or neurosyphilis, structural causes like a chronic subdural hematoma or certain tumors, and also different genetic disorders as well could all mimic Parkinson's disease.
Yeah, so definitely going to be important. And honestly, this is something that most likely needs to be worked up by someone that is working directly in neurology and not done like in a primary care setting. These patients need to be seen by neurology and followed closely by neurology to make sure that the diagnosis is correct. Hey guys, I'm sorry to interrupt the episode, but I wanted to tell you briefly about our sponsor, Freed AI. Do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed is an AI scribe that makes charting go away. It does your notes for you. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient walks out of the room. Freed learns your style over time, just like a human scribe would. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. You can try 10 notes for free, and after that, it only costs $99 per month. You can find out more information at their website, www.getfreed.ai. Check them out today. Back to the show.
Yeah, a lot of big medical centers do have good movement disorders clinics.
Yeah.
And so, they'd likely initially be seen by Gen Neuro and then may end up being referred to the movement disorders clinic, depending on what the determination is.
Right. So we'll jump into some of these medications, but the main kind of target that we're trying to accomplish is making sure that we increase the amount of dopamine available. And so there's certain enzymes like monoamine oxidase B, COMT, and just the precursors for dopamine like levodopa, that we can presynaptically increase the amount of dopamine getting into that, or attaching to the postsynaptic neuron, dopamine receptors. And so we'll start off with the kind of the mainstay of Parkinson's disease treatment, and doesn't always have to start with this medication, but in almost every case you're going to end up eventually being on this med. It's the carbidopa levodopa. So like I said, levodopa is the precursor of dopamine. Carbidopa is there because it's inhibiting the enzyme dopa decarboxylase. So that's going to prevent the peripheral metabolism of the levodopa, allowing it to be converted into dopamine. So the carbidopa is not necessarily adding to the therapy itself. It's allowing the levodopa to actually do what it needs to do. The dosing is kind of starting off 70 to 100 milligrams per day is what's required for the carbidopa to inhibit that enzyme. But the dose of levo really depends on the patient, and we obviously do not want to give them too high of a dose because that can lead to a whole number of side effects. And there are several different formulations. Typically, like the immediate release formulation, you're taking it 3 times a day, sometimes more. There's a controlled release that you can do twice a day, and we'll talk about some of those in a second. But some indications to levodopa, carbidopa would be patients that are taking non-selective MAOI inhibitors. So things like for depression, so the actual MAOIs like we think about, and not the MAOI-B inhibitors like we use in Parkinson's, so the non-selective ones. You can't use those within 14 days, or patients who have narrow angle glaucoma. And so obviously if they're dealing with that, they need to be being seen by ophthalmology and getting that managed anyway. But those are things that are considered contraindications to taking levodopa. Some adverse effects to keep in mind, nausea, dizziness, orthostasis, and then the big one, dyskinesias, like we mentioned earlier. 1/3 of patients will develop, confusion as disease progresses, and they also may experience a darkening, even like a brownish coloration of their urine. So making sure patients are aware of that, because obviously that can be alarming.
Right. You mentioned some of the other dosage forms. So there's Cinemet CR, that's the extended release tablet. Parcopa is an ODT tablet. That can be helpful with swallowing issues. There's Rytary, I don't know how to pronounce it, but that's the extended release tablet. It's used pretty regularly. It can lead to reduced number of daily doses and potentially reduce motor fluctuations. Somewhat of a higher cost. The cost has come down pretty significantly over the years. Most of the time it can be covered with Medicare if they've tried the Cinemet first, and usually there's a reasonably high copay, but there are like the Pan Foundation and other foundations that can help with that too. So there's inhaled levodopa, which is Embrija. This is used more like an acute PRN medication for off episodes in patients who also take oral levodopa. Then there's some drug interactions to be aware of. So don't use them with dopamine blockers like promethazine and metoclopramide. Kind of touched on that. Iron can decrease the carbidopa-levodopa absorption, so be aware of that. It's not going to take an immediate effect, so it can take several weeks before the patient feels the effect, and you're not supposed to abruptly stop carbidopa-levodopa. You can see worsening of symptoms if that happens. Also notably, it may increase uric acid slightly. So for a patient with gout, that might be something to monitor.
And Cole mentioned, some on-off periods. There's some terms we got to make sure that we cover, just because as we go into these other medications, it's important to know what kind of, which of these the patient's experiencing, so we know kind of how to handle the medication, whether we just increase the dose of the levo or we start using adjunctive therapies, and then which adjunctive therapies we actually go with. So things like wearing off phenomenon, basically just the patient is having a return of their symptoms, their motor function symptoms before their next dose. So you can kind of time it to where, an hour before they're due for their next dose of carbidopa, levodopa, their symptoms start to come back. The on-off periods, like Cole mentioned, is sort of this unpredictable return of Parkinson's symptoms. So like we mentioned, the inhaled levodopa, that would be more indicative for like treating that situation, to where you're not able to predict when it happens. So it's almost like a rescue treatment, so to speak. And so it's not, happening in respect to the dosing interval. It's just occurring unpredictably. There's also like delayed on or no on responses, which is just like a delayed or absent onset of the effect of the actual drug. So, individuals may just be on too low of a dose, or, they may have some other interaction that they're not aware of. And, that can obviously result in the delayed like delayed gastric emptying or decreased absorption in the duodenum, and things like that can cause the medication to not be systemically at the level that we would expect. So there's some things we would have to look at if that starts to occur. And then patients that are experiencing freezing, it's a sudden episodic akinesia of the lower extremities, and as patients may say that they're feeling like their feet are suddenly stuck to the floor during ambulation, and they have difficulty initiating steps. They have that start hesitation, and that can obviously increase the risk of falls and things like that.
Right.
So depending on which of those, and we'll kind of cover that at the end, but depending on which of those the patient is experiencing, we kind of can go from there as far as which medications we may need to add or what we need to do with the levo dose.
Yeah, we'll circle back to that.
I wouldn't double click on that.
Yeah. You want to mention the password?
Yeah. Let's do the password. So for those of you who are using this to get your 1 hour of continuing education credit with free CE, you'll go to their website and click on this episode and then use the password tremor, all capital letters, tremor, and it'll be a 10-question multiple choice test, exam, quiz, whatever you want to call it. Pass that, and you'll get your 1 hour of continuing education credit for pharmacists and nurses.
Nice. I guess I kind of do the double click thing, but I say highlight. I'm like, let's highlight this real quick. When I'm like counseling people too, I say, okay, I just wanted to highlight a couple things for you, and I guess that's the same thing because it's an analogy for highlighting things with a highlighter, I suppose.
I think it's exactly that analogy.
Maybe I'm annoying as well. Maybe
patients are like, gosh, I'm never going back to that guy.
I'll just embrace it and switch to double click. So
I think highlighting is way better. Double clicking is like the nerdiest thing I've ever heard.
What happens if you single click on something? You just glance over it.
Yeah, you just click it where it's like, okay, what now? You just highlight. Technically you highlight it.
What about if you right click on something?
Yeah, well then you pull up the properties.
Yeah.
That's if you want to do a real deep dive.
That's an
let's right click on this and let's go deep.
Yeah, I like that. I'll do right click and just circumvent everybody.
Yeah, there you go. It's a good idea.
So Mike mentioned COMT. So there are drugs that inhibit COMT, catechol O methyltransferase, which will prevent, by inhibiting it, we're going to prevent peripheral and central conversion of levodopa to the active form. It's only used with levodopa. Interestingly, there's a 3-drug combo of, I haven't mentioned the name of the drug, entacapone. There's a brand name, which is Comptan, but usually entacapone is what it's referred to as. There's a 3-drug combo called Stalevo, which is entacapone, carbidopa, levodopa. The dosing is 200 milligrams with each dose of carbidopa, levodopa, max of 1,600 milligrams per day. The adverse effects of it are similar to levodopa, and when you start it, the levodopa dose may need to be decreased by 10 to 30%. So keep that in mind.
Yeah, and I think you're basically allowing even more of that levodopa to get into the system than you would with just the help of carbidopa. So you obviously need to take that into account. Otherwise, the patient will develop those dyskinesias. And then opicapone is another COMT inhibitor. This was FDA approved in 2020. And then, again, adjunctive therapy to someone who's on levodopa, carbidopa, and it's only used in patients taking levodopa. So you're not using this ever as a standalone agent, and it's taken at bedtime. No food 1 hour before and after the dose, and you need to avoid use in patients with severe hepatic impairment, being a Child-Pugh score of C, or if creatinine clearance is less than 15 mils per minute. Adverse effects, kind of like Cole mentioned, you do got to worry about obviously just more of that levodopa in the system. So the dyskinesia is the big one. Also constipation. There could be some increased blood creatine kinase levels, hypotension, syncope, decreased weight have been reported, and again, same kind of decrease in dose of the carbidopa, levodopa, or specifically the levodopa, but 10 to 30% when you add that COMT inhibitor to make sure that you avoid the adverse effects as best you can.
Right. So all of these meds up to now have been related ultimately to levodopa or to promoting levodopa. There are instances where dopamine agonists are needed, and we'll touch on this at the end as kind of where they fit in, but examples of dopamine agonists are pramipexole, ropinirole, and then there's also rotigotine, which is the Nupro patch. The other drugs are oral. Both pramipexole and ropinirole are used or are available in extended release formulations. Usually you'd see them used for like restless leg syndrome and that sort of thing. But they act similar to dopamine at the dopamine receptor. So they're agonizing dopamine. They have adverse effects associated with them: somnolence, nausea, dizziness. Orthostasis can be a big one, hallucinations, and dyskinesias. Also, with the Nupro patch, there can be some irritation or reaction at the application site sometimes. Pramipexole has renal dose adjustments if the creatinine clearance is less than 50 milliliters per minute. And when used for restless leg syndrome, they're usually dosed around bedtime.
Yeah, and I think that's, the hallucinations side effect. Obviously, the patients who do start to develop, the psychosis because of the Parkinson's disease, it can be hard to differentiate between the dopamine agonist causing it versus the patient's, worsening symptoms. So obviously, it may be a drug that needs to be discontinued, or the dose increase if the patient does start having that, to see if it's coming from the medication and not just assume that the patient's starting to have psychotic side effects of the actual disease. Right. There's another dopamine agonist called apomorphine, and there are two different formulations. There may actually be more now, but the two that are most common: sub-Q injection, and then there's a sublingual film. And these are used again for like an acute episode of an on-off period. So the patient has like this sudden off period, again, where they can't predict when it's going to happen. That's when they would use this as a potential, on-demand relief treatment, rescue treatment. The initial dose, as well as when there's dose titration, must be administered by a healthcare provider due to the risk of hypotension and syncope. And to achieve an off state during initial dosing, in clinic, the patient is basically told to avoid their Parkinson's meds after midnight the night before, and then hold their morning dose of carbidopa, levodopa, or any of their adjunctive meds as well. And that way they can get their first. They would basically have an off episode in the office, and then you would treat them with this to make sure the dose is going to be proper. And then some other adverse effects besides the hypotension and syncope would be chest pain, nausea, dizziness, and then obviously the hallucinations, because you're increasing that dopamine.
Right. And I've seen these used a few times. It's kind of the same idea as the Inbrija.
Yeah, exactly.
But for people who need dopamine agonists. The injection one is kind of strange. I think it uses like cartridges and stuff. But anyways, there's also monoamine oxidase B inhibitors, the Mike referenced before, which are okay to use with the carbidopa, levodopa, because they're not non-selective monoamine oxidase inhibitors. Selegiline, rasagiline, and sulfonamide. So selegiline is an older one. It's dosed 5 milligrams twice a day with breakfast and lunch, or in the early afternoon, either lunch or early afternoon. It can be stimulating, so you don't want to give it at bedtime. And it's only approved to use with levodopa. If it's being used as monotherapy, that's an off-label indication. Rasagiline or Azilect is relatively newer compared to selegiline. It's 0.5 to 1 milligrams a day. It can be used as initial monotherapy or as an adjunct to levodopa. This is the one I see used more often. There's also one called, branded as Zadago, that's sulfonamide. It's started at 50 milligrams once a day. It can be increased to 100 milligrams after 14 days, depending on how they're tolerating it. It also is indicated for monotherapy or adjunct to levodopa. Some interactions to be aware of with them are with serotonin. So meperidine, for instance, could be a very significant interaction with monoamine oxidase B inhibitors. Tramadol as well, methadone, mirtazapine, cyclobenzaprine. Also, tyramine-rich foods. So they do have tyramine foods have monoamine or MAOA inhibition at higher doses.
No, the drugs have some MAOA inhibition at the higher doses. So the tyramine-rich foods at certain doses could come into play, just like you would with the MAOI inhibitor, like we think about with,
Right. And the concern there is that it could cause a hypertensive crisis. Tyramine-rich foods being like if I recall correctly, like what wines and cheeses.
Yeah, it's like charcuterie type foods, I think.
Yeah, anything you would get on a charcuterie board is thiramine rich. But they do have some adverse effects, pretty well tolerated, but nausea and headache are the most common. Also falls, trouble sleeping, dyskinesias can occur, but it may also just be manifestations of advanced Parkinson's disease. Sellegeline can cause confusion in older adults, more so than the other ones, so be aware of that.
And then we also have a newer agent that is a new class of medication. It's istrophenylene, and it's known as a adenosine A2A receptor antagonist. And so this is another adjunctive therapy to levodopa that can be added on for patients who are having wearing off symptoms. And studies showed it reduced daily off time by approximately 1 hour. Adverse effects with this, dyskinesias, dizziness, constipation, nausea, hallucinations, and insomnia. Basically the same kind of thing. When you're increasing the amount of dopamine, those types of side effects are going to be there. And then avoid use in patients that are taking a strong CYP3A4 inducer, because this is a substrate of 3A4. And then smoking 20 cigarettes or more per day can decrease, which is a pack a day, can decrease the steady state systemic exposure of the drug by 38 to 54%, depending on a couple different kinetic studies that have come out. So making sure that you're adjusting the dose for patients that are smoking, especially if you have more heavy smokers.
Right. There's also a couple of medications that you're not going to see used too much for this reason, but are out there, are centrally acting anticholinergics like benztropine or trihexyphenidyl. They seem to improve motor functions in Parkinson's disease, but the data is kind of mixed as to how well. You'll see like benztropine used in what is it called? Like antipsychotic induced.
Yeah, for like TD.
EPS.
EPS,
yeah. Benztropine would be 0.5 or 2 milligrams 3 times a day, starting at bedtime. It's used primarily for tremor. And one of the concerns is the anticholinergic side effects in the elderly. So that's one of the reasons it's not great for these patients. Drowsiness, confusion, that sort of thing. Trihexyphenidyl really is not used too much. It would be dosed 1.5 milligrams 3 times a day, starting with 1 milligram at bedtime.
Yeah, I don't think I've ever seen these used for actual Parkinson's. Have you?
No, I have not.
No. Yeah, the anticholinergic effects alone are pretty brutal.
Yeah.
And then we have a very old drug that I believe by definition it's like an antiviral, actually, because I think they tried to use this for like flu like back in the day, but amantadine. It does have symptomatic benefits that may help to reduce dyskinesias. So you're actually helping with the side effect of extensive use of levodopa or the dopamine agonists. And so if the patient is having dyskinesias, then amantadine can potentially help to lessen the extent of those. And then it's working by blocking dopamine reuptake into the presynaptic neurons. So it's increasing dopamine release from presynaptic fibers, but blocking the reuptake. And then it's dosed at 100 milligrams twice a day to 3 times a day. And it does have renal dose adjustments that you need to take into consideration if you have a patient with CKD. It does have some adverse effects like dizziness, insomnia, and then in some rare cases, toxic delirium. And in even more of a rare situation, it can actually cause a cutaneous reaction that's basically like a reddish skin molting scenario. So that would obviously not be an ideal situation to have to deal with. But if the patient is having dyskinesias that are so bad and can't, get the dose of the levo or the dopamine agonist correct, and this may have be an option that you have to go with.
Right. Okay, so now we'll circle back to what we had talked about earlier, which is where some of these things fit in and where you might use what in what situation. So you have a diagnosis of Parkinson's disease. You want to identify the presence and symptoms of impairment. Are they having non-motor symptoms? Are they having motor symptoms? If they're having non-motor symptoms, identify that, manage that. It's kind of separate from what we're talking about today. If they don't have significant impairment from their symptoms, you could consider rasadrenaline here. Are they having tremor, is the tremor causing impairment. Depending on their age, may steer us in one direction or another. So if they're under 65 years old, you could still consider an anticholinergic medication because the risk of anticholinergic side effects is not as severe. Otherwise, you would go with carbidopa-levodopa.
Plus, the dyskinesia risk goes up with age as well. So if you're starting at less than 65, the odds of you being on levodopa, for the rest of your life are obviously going to be high, and then the risk of dyskinesia is just going to continue to go up. So they're trying to limit that risk too, but the anticholinergic effects may not be ideal either. So it's going to be kind of patient specific.
Right. Good point. If they're over 65, then carbidopa-levodopa is probably what you're going with. Addressing the bradykinesia and rigidity. If they're over 65, you'd want to use carbidopa-levodopa. Under 65, you could consider a dopamine agonist, and then probably move on to carbidopa-levodopa after that. Postural instability or gait impairment. Under 65, could consider a dopamine agonist. You also want to have them in physical therapy for this as well. Over 65, carbidopa-levodopa plus physical therapy. And then motor symptoms are probably going to continue, and then you kind of adapt from there with trying this or that, or moving on to different formulations of carbidopa-levodopa. And there is also a deep brain stimulation option, which I haven't run into a patient who's had that done, but I suppose is done.
Well, and besides just traditional physical therapy, there's also some programs that there's one locally in Charleston called Rock Steady Boxing that it's like a boxing class, but it's made with those exercises that are geared specifically for patients with Parkinson's disease. And I've watched a few of their classes, and it's a really, really good program that's gotten some great results. I want to say maybe even MUSC is actually doing it now. But it started off at a little gym that they had gotten, they had learned how to coach and do that program from whoever started it in, a much bigger city than Charleston, and brought it here. And it was a very cool program to see, and the patients, in fact, one patient told me that their tremor and their other motor functions had never been better controlled until they started doing that program. So there's some things like that may be a little bit more fun than traditional physical therapy.
Right. But in general, staying active and doing something like that is very important, even though it may seem like a challenge because a lot of their symptoms are related to motor issues and walking and ambulating and things like that. But this activity can be very beneficial.
Yeah. So as far as adding adjunctive therapies, a lot of times, we're going to end up with starting off with carbidopa-levodopa with a lot of these patients, especially like Cole said, over 65. There are a couple studies that have looked at the various options that we can do, as adjunctive therapies and what to add, which ones would be better to add. And there's a study called PD-Med trial, and it included 500 patients with Parkinson's disease and motor complications that were currently taking levodopa therapy. And they were basically assigned to either taking a dopamine agonist, COMT inhibitor, or an MAO-B inhibitor. They based the primary outcome on that 39-item Parkinson's disease questionnaire, the PDQ-39 mobility domain. And the scores were improved in the dopamine agonist group compared with the enzyme inhibitor group, so the COMTs and the MAO-Bs, but the result did not reach statistical significance. The mean levodopa doses were the lowest when combined with dopamine agonists, and the MAO-B inhibitors resulted in better average mobility scores compared to entacapone, which was the only COMT inhibitor that was used in that study that didn't include opicapone.
Yeah. So when you're treating these patients, a lot of times there's going to be issues as the disease progresses, and you're going to have to do a lot of pharmacotherapy changes based on what's going on with them at that time. You'll get messages from the caregivers about what's going on, and you'll have to adjust things depending on when their off episodes are happening. And so here's some kind of guides to addressing some of those things. So if they're having an end of dose wearing off, like Mike mentioned before, motor fluctuations there, you may need to increase the frequency of the carbidopa-levodopa doses, add or switch to extended release carbidopa-levodopa like Rytari, adding an adjunctive therapy like Mike was talking about, COMT inhibitors, MAOBs, dopamine agonists, Nurians. Those are all options for if they're having end of dose wearing off. Acute off episodes, this would be where the kind of fast-acting things come into play. So the Inbrija inhalation or the apomorphine injections or sublingual films.
And if they're having like a delayed on or no on response, making sure that the patients are taking the carbidopa-levodopa on an empty stomach, especially if they're likely to be eating like a higher protein diet that may be competing with the absorption of the medication, and it may not be getting the systemic levels that we're assuming it is. There's also the ODT carbidopa-levodopa, like Cole had mentioned, that may be more beneficial than taking it orally, like traditional oral tablets, and then trying to avoid the original like sustained release, and using a different formulation. Also, if the patient's having like freezing or that start hesitation, they may need an increase in their carbidopa-levodopa dose. You can also consider adding a dopamine agonist or a MAO-B inhibitor. And then again, like we mentioned, physical therapy, along with assisted walking devices or certain things like sensory cues, like rhythmic commands, stepping over objects, and like kind of working through that process to sort of help them get over that start hesitation and work through that can be important. And then if they're having peak dose dyskinesias, so they're having the dyskinesia as a result of the levodopa dose, they may end up needing to decrease that or reduce the dose of the adjunctive dopamine agonist if they're taking that as well. And then we also have amantadine in our back pocket if we absolutely need something to help reduce those dyskinesias after we've tried to mess with the levodopa dose as best we can. Right. But not something you want to just jump to, but it is a potential option.
Yes.
Anything else with any of the drugs, man?
I think we hit the majority of the stuff. There's other movement disorders topics that we'll be able to do in the future and that have a fair amount of new drugs over the last few years. We've touched on a little bit of it, but we'll need to do that at some point.
Yeah, for sure. But I hope that was beneficial. Good review for you guys. If you do have any questions or anything, let us know. Make sure that you go to FreeC's website and take the 10-question exam, get your 1 hour of continuing education credit. And if you want more like lecture style content, check out patreon.com/coreconsultrx. We have new lectures that are uploaded there and PowerPoint slides that go along with them that you can download, and doing case presentations and some other things on there as well now. And also check out pearls.com/coreconsultrx. Pearls is a ever-growing drug information pharmacotherapy review chart app. They have a desktop app as well as a mobile app as well. And it's a great service that is very affordable, and the content they're adding now is increasing, I feel like, weekly. So they're a great resource for various pharmacotherapy treatment algorithms and things like that. And if you sign up for the Patreon and you sign up for a whole year's worth of the membership, which is like $30 and some change, I think, you will get a free copy of Dr. Alex Poppin's book of High-Powered Medicine, which is the landmark clinical trials review book that he published. It's the second edition. He's currently working on the third, but you'll get a digital copy of the second edition. It has over 150 landmark trials and reviews and summaries of those studies, and it's a great reference tool that I use quite a bit myself. So you will get that if you sign up for a year to the Patreon. So much learning potential. So hope that's helpful for y'all. Let us know if you have any questions or any comments, concerns, anything like that. And we will see you guys on the next episode. Have a good one.
Before we sign off, do you mind if I do a little promotion real quick?
Yeah. No, go for it, please.
it's more of a pre-promotion, and I realized that in the 7 years we've been doing this is the first time I'm promoting anything.
No, this is great. This is really cool. Go for it.
I want to highlight it real quick. It's a pre-promotion because in true Cole fashion, it's not actually released yet, but I've been working on a little side project that was initially for myself. Actually, it was to help me cram for researching for the podcast right before we record for you guys. Basically to make researching online for medical stuff a little bit quicker and more efficient. Basically, it's a Chrome extension that you'll be able to add to your Chrome browser to effectively search for any term or phrase or symptom or medication, either with a click of a button or with a hotkey to any medical resource that you can think of. Lexicomp, UpToDate, Hippocrates, Medscape, PubMed, whatever. So basically, if you have it enabled, you'll be able to highlight a text and click and search any of those. The hotkeys are customizable. The websites that you use are customizable. I have about 20 websites that are going to be loaded on there. But if you have ones that you want to use that are able to be searched, you can add any website onto it and incorporate it into the browser. Even if it's not medical, you could do that too. But it'll probably be released in the next couple of weeks. I'm hopeful that the name will be able to be MedSearch as long as that's approved. So it would be the MedSearch Chrome extension. Anybody can try it for free, and then there'll be a small cost just to cover the cost of having it there and also supporting us in the podcast and stuff like that. So hopefully I'll do an official kind of promotion of it when it's actually released in the next episode or two. So be on the lookout for that. There's all sorts of other cool functionality I would like to add to it if people are interested, like integrating it with other browsers. At the moment, it would only be for Chrome, but if you're like, shoot, I use Microsoft Edge or whatever, I can do that. It would just take a little time. Searching 2 websites at once, searching in the side panel of the browser, copying and pasting drug lists into interaction checkers so you don't have to add them all individually. A variety of things I could do. So if any of that interests you or you have an idea for it, shoot me an email that's in the show notes or once it's released, you can definitely give me some feedback. So yeah, MedSearch is what I hope it to be called.
Very cool, man. I'm looking forward to it myself.
Thanks.
All right, you guys. We'll see you next time. Bye.